This is Iyad Al-Nahas. This presentation is an overview of a chapter written on Approach to the Patient, Clinical Features, Neurology of Brain Tumor and Paraneoplastic Disorders. This chapter reviews the most common clinical symptoms that accompany primary and metastatic brain tumors. Symptoms from primary or metastatic brain cancer can vary in presentation. Symptoms may present acutely, as in seizures, hemiparesis, or obtundation due to hydrocephalus, for example. Symptoms may be more progressive, on the other hand, such as headaches or progressive cognitive changes. Symptoms may be focal, as in focal weakness, facial droop, or a specific cranial nerve palsy, but symptoms can also be more generalized, as in seizures or cognitive changes. Finally, cancer neurology symptoms can present either centrally, as in headaches or seizures, or can be peripheral, as in neuropathy or autonomic dysfunction. Discussing one symptom at a time, we start with headaches. Headaches can be the presenting symptom in about 25% of patients with primary or metastatic brain cancer. And based on the International Headache Society classification of headache disorders, headaches related to intracranial neoplasms are often progressive, worse in the morning, associated with postural changes, i.e., worse when supine or bending over, and are often associated with nausea and vomiting, especially when there is increase in intracranial pressure. It is thought that the meninges and their associated portions of the cerebral vasculature are the only intracranial sites from which pain can be evoked, and the distortion of the meninges by increased intracranial pressure due to tumor mass, vasogenic edema, or hydrocephalus can generate headaches. We next discuss seizures. The incidence of seizures in patients with brain tumors has been variably reported to occur in 20 to 70% of patients. Patients with WHO grade 1 tumors such as DNETs or gangliogliomas are more likely to have seizures. Interestingly, more recently, it was shown that gliomas that harbor the IDH mutation are more likely to be associated with seizures, and that's due to the increased production of alpha-hydroxyglutarate, which mimics the activity of glutamate on the NMDA receptor. In terms of seizure management, it is thought that surgery can frequently help with seizure management. Also, the use of newer, non-enzyme-inducing anti-epileptic medications such as levetiracetam, lacosamide, or lamotrigine is favored over the use of older AEDs given less interactions with chemotherapy. Finally, per the AN guidelines, prophylactic anticonvulsant use at this time is not warranted unless patients have had seizures. Cognitive dysfunction is very common in patients with brain tumors. It is estimated that over 90% of patients with primary or metastatic brain tumors have a degree of cognitive dysfunction, and that's even prior to surgery or any other treatments. Even intracranial extraaxial tumors, such as meningiomas, can be associated with significant cognitive decline. Cognitive dysfunction in the spheres of language, personality, behavior, or cortical sensory recognition or visuospatial functioning can occur in patients with brain tumors when the frontal, temporal, or parietal lobes are involved. Management of cognitive dysfunction has included preventative strategies, medical therapies, and coping strategies usually administered by speech pathologists. Stimulants such as methylphenidate have shown benefit in addressing cognitive dysfunction in patients with primary brain tumors in some studies. Treatment with memantine, an NMDA receptor antagonist used in the treatment of Alzheimer's disease, delayed cognitive decline in patients with brain metastases who underwent whole brain radiation therapy. Psychological, behavioral, and psychiatric symptoms. Patients with brain tumors frequently have comorbid psychological symptoms, which are often underrecognized or unaddressed. Adjustment disorder and acute stress disorder were the most common psychiatric diagnoses, with most patients experiencing high psychosocial distress. Steroids, which constitute a mainstay in the management of vasogenic edema in patients with brain tumors, are also associated with side effects including depression, euphoria, and paranoid ideation and anxiety. Focal symptoms usually depend on the location or lobe of the brain that is affected by the tumor or treatment effects. For example, involvement of the frontal lobe frequently presents with loss of initiation, apathy, and impaired planning and executive functioning. Temporal lobe involvement, on the other hand, commonly presents with seizures as well as impairment in memory and language. Parietal lobe involvement can lead to cortical sensory deficits as well as hemineglect and apraxia. Patients with occipital lobe involvement frequently have visual field cuts, and with cerebellar involvement, usually patients present with ataxia and dysmetria. When the brainstem is involved, usually cranial neuropathies emerge, as well as at times hemiplegia and hemisensory deficits. The cerebellar pontine angle tumors usually lead to unilateral hearing loss, tinnitus, and vertigo. Patients with pituitary problems usually present with pituitary hormone deficiencies, as well as potentially bitemporal hemianopsia. And finally, patients with pineal involvement can present with hydrocephalus, headache, and Paraneoplastic syndrome. Paraneoplastic neurologic syndromes are a diverse group of disorders that are caused by mechanisms other than the tumor itself. The syndromes can present prior to the diagnosis of the underlying malignancy. It is postulated that an immune response to the cancer may underlie the pathophysiology in most cases, i.e., molecular mimicry. For patients with an established diagnosis of a paraneoplastic syndrome, regular cancer surveillance becomes necessary. Antibodies can be targeted against intracellular antigens. Classic examples include anti-Hu antibodies, which lead to limbic encephalitis, cerebellar degeneration or neuropathies, and are common with small cell lung cancer. Anti-Yo antibodies can lead to cerebellar degeneration and are common with breast, ovarian, or other female reproductive tract cancers. Anti-Re antibodies can lead to opsoclonus myoclonus, which is commonly seen with ovarian teratomas. On the other hand, antibodies can be targeted against neuronal surface antigens, and classic examples of this include anti-NMDA receptor that commonly lead to encephalitis and is also common with ovarian teratoma. This concludes this presentation. We hope that you go back to the chapter for more details.